Welcome to the Right Tack, where we help private practice owners face the headwinds of the healthcare industry. I'm Paul Jonas, CEO and co-founder of Breezy Billing and Phoenix Credentialing.
Well, and I'm Jim Jonas, therapist, co-founder of Breezy Billing, Phoenix Credentialing, and the Jonas Center.
Today, we're joined by a returning guest we're excited to have back, Dr. Talha Baloch. In episode 5, we spoke with Talha about co-working and office sharing and the business he started with his wife that they call Mindful Spaces. Today, we're talking about his other passion, how combining medication and therapy can optimize care for mental illness and addiction.
In addition to Mindful Spaces, Talha has a long list of things that I'm going to read. It's an impressive. Okay. President, lead psychiatrist at Comprehensive Psych Solutions, triple boarded. Not single boarded, not double boarded, triple boarded. Okay. In general psychiatry, addiction psychiatry, and addiction medicine. He's presented at national conferences for organizations like the American Psychiatric Association, the American Neuropsychiatric Association, the American Academy of Addiction Psychiatry, and many more. His interests include cross-cultural psychiatry, ethnic diversity, stigma resolution, and mental health advocacy.
And today he's here to talk about a topic that affects nearly every behavioral health practice, the role of medications alongside psychotherapy, and how therapists and psychiatrists can work together for better client outcomes.
Talha, welcome back to the Right Tack. It's great to have you with us again.
Thank you guys so much for having me back. It was such a fun time the last time we were together, and I was like, if we can get back on the show here, let's do it. So thanks for having me on.
That's fantastic. We're really excited to have another good conversation, and I don't know, it's always good. So this will be a cakewalk. We're gonna have some fun today.
Well, what the heck,
and learn something too. Yeah.
You know, had we talked about this at the party, Talha, when like having a podcast with this topic
on the psychiatry side?
Yeah,
I don't know. I know we were thinking it if we did talk about it.
It'd be good. It's really good for therapists to have this conversation. So yeah.
So we'll dive in. Yeah. Oh, go ahead.
I was just saying, yeah, absolutely. The connection that we had, with mental health and therapy and medication management, it goes hand in hand. So to be able to bring it together for the audience, I think it's going to be really important.
Yeah. Awesome. So we'll get into that. But before we do, we like to ask that question, and you already know this as a returning star. What you got going on this weekend, Talha?
Well, I don't know if you guys remember from last time, we were expecting our first child. And so now we have welcomed her. And so our hands are pretty full with that. A lot of low-key weekends for us, family time. We might get out, introduce the little one to some snow, depending on how cold it is outside. But, as you two are very experienced in this, our schedules now revolve around nap time. And then our coffee breaks in between. So nothing too adventurous, but it's enjoyable. Yeah.
Is she sleeping through the night? Is she sleeping through the night yet?
She has her nights. Yes. Some nights we'll go, 8 p.m. till 7 a.m. And then there's the other nights where we're getting up quite often, but it's a good opportunity for me to refresh how it used to be while I'd take call at the hospital, getting paged through the night. It's like,
right.
It's like residency all over again.
Right. Oh man. Yeah.
Awesome. Well, how about you, Dad? What do you got going on this weekend?
This weekend, I was thinking splitting wood, maybe. I have to tell you about the cylinder too.
Oh yeah.
So I'm probably going to go get our cylinder for the wood splitter, the one that isn't working. We had to redo it, the whole thing. It's a long story. They couldn't clip it. So they couldn't get the clip out. Yeah.
We'll have to, I can't wait to talk about it.
Oh, there's good.
Maybe not on the podcast.
Oh, well, okay.
But that sounds very exciting.
Oh, it's exciting. What about you?
Well, we're getting a new fridge this weekend.
Oh boy.
So this thing is 10 years old and the ice maker died on it. So if there's ever a symbol that it's time to get a new fridge, I think it's going to be that. We've already had to manually defrost it a few times too, like take things apart with a hair dryer and all that.
So
so I think it's on its last leg, and I can't wait to see how it works.
Okay.
Well, so we got that going this weekend, but let's talk about bigger things. Let's talk about some fun stuff. Let's talk about the role of medication in mental health management.
All right. Why don't we do that? Alongside psychotherapy, how does that work? And if we start out broad, Talha, can you give us some comments about that?
Absolutely. In my ideal world, therapy and medication would be like two hands steering the same wheel. And therapy is what gave, patients insight, coping skills, pattern recognition, the tool that really brings change to their lives. And medication, when it's appropriate, provides a lot of the biological stability that makes those tools actually usable. So the best partnerships, in my opinion, are those where a therapist and a psychiatrist are in communication, are collaborating, so that the interventions that we utilize aren't competing with each other, but rather reinforcing each other. And we can get better outcomes, sooner outcomes, and have people living really healthy lives.
Okay, and so you haven't so it's not always the answer, but it can often be very helpful, it sounds like. And it sounds like it can be essential too to have those tools work. So how do you help people or providers navigate that balance?
I think one of the basic things we have to do is just normalizing the full spectrum of treatment and what that looks like. Some people need medication and some people don't, right? And some people need short term support and some need long term or lifelong management of symptoms. And all of those are very valid treatment options and approaches. And what I often try to do is I walk through my patients through evaluation, understanding their
Mhm.
symptoms, to learning about their background and then going over treatment options. And so we explore, the biological components, the psychosocial components, and trauma and this and that, and everything that comes together to bring them to where they are at this point in their life where they're seeking care. And so that way we can make a shared decision on what we want to do to move forward. And when it comes to medication, at the end of the day, I always emphasize medication has side effects, right? And we want to be
Mhm.
conservative with the medications that we use. The goal is to find the right med at the right dose for the right amount of time versus no meds at all, maybe. And so those are
Mhm.
really important things for us to all work together to explore. And we work with the patient on that, right? Because we want them to take control of the direction they're headed with their healthcare. And we want to be a tool that they use to get to where they want to be in life.
Okay, so Tala, as you're talking about this, I'm thinking of the importance of getting the diagnosis right, and I mean, you're talking about symptoms and uh, what, just making sure you've got the symptoms, psychosocial history, those kinds of things, and making sure that you've got that right. I'm assuming that is helpful then in determining what kind of med you might prescribe or not. Is that right?
Absolutely. I mean, if I had to say diagnostic clarity is kind of everything in our field, unfortunately, in mental health and psychiatry, we don't have the lab work that other fields of medicine do. We can't get an EKG and say you have, a heart attack at the moment, or we can't get lab work for your cholesterol and say you have hypercholesterolemia. We do a lot of conversation based evaluations that helps us get to these diagnoses, and so that clarity is everything, right? And without it, you end up treating the wrong thing at times. One of the big examples I like to give is the crossroads of ADHD, trauma, and anxiety. They can look so similar on the surface, but require totally different strategies to manage. Or someone who's depressed, for example, the root issue may be major depressive disorder, a unipolar depression, or a bipolar depression. And so, in a situation like that, giving an antidepressant to someone who has bipolar can make things worse. And we also have
Mhm.
to remember that a lot of these conditions can also be the cause of medical complications, right? Or medical conditions that mimic mental illness. Hypothyroidism, for example, is a really big cause for depressive symptoms, low energy, low motivation, low drive, sluggishness. So when we do our intake evaluations, that diagnostic clarity, one with interview, but two, we still do get lab work to rule out some of these medical conditions. So making sure you get a thyroid test, making sure you get test for anemia, if they're feeling lethargic and fatigued, are we missing something else? Or if we're in the Midwest, vitamin D levels play a big role in mood. Are we checking for these things? So always getting lab work in the beginning, making sure we're not missing anything, and then just really making sure we spend the time to understand what they're presenting with. So the clearer the diagnosis, the more targeted the treatment plan can be, and the better the outcomes will be at the end of the day.
So just curious about something with the, are you often working with people on the medical side too, physicians or PAs, nurses, something along that lines?
In terms of like
getting to, like, for some of the tests that are administered or some of the medical conditions that might be getting diagnosed, like, are you getting referrals from the physical medicine side, in addition to the mental health side? Like, it sounds like there's kind of three sets of folks involved, whether it's, the psychotherapy to psychiatry to like a primary or something like that.
Yeah, so a lot of the times, if I get a referral, say from like a primary care doctor, they will have already probably worked up a lot of the medical causes for a presenting complaint. And they may have even tried some psychotropic medications, and they may say, hey, maybe this is above my understanding. Let me send you to a specialist. And then they refer them to me. Versus people who just come see a psychiatrist directly may not even be aware that we should be looking into medical causes. So I order lab work on my own. I send them, send the orders in, they get it done. We make sure that everything looks good. If something comes back off and it's like, hey, I understand that I tested for the thyroid concern, but because there's something off here, I want you to see an endocrinologist to make sure that you are getting this treated accordingly. And then come back and tell us how things are going. And maybe we still need to treat the depression, but maybe once the thyroid is addressed, you may not have those symptoms. So we work really collaboratively with all of these folks.
Okay. And that just sounds like a lot of moving parts to kind of keep in consideration as you're working with these patients.
Yeah,
absolutely.
So, I don't know. We've talked before about the stigma around mental health and management and medication, like, and that being a barrier to treatment for some people. So, what are some of the major hesitations or fears that you're hearing or finding when you're working with folks?
Yeah. I think the biggest fear that most people will share with me is the idea that if they start medication, they'll have to be on it forever, or it'll make them numb or feel like a zombie, or it'll change their personality. And then there's also the idea that being on medication somehow makes you weak or that you're a failure. And none of that's true at all. I think what has happened is oftentimes medications may have been used, they may have not been appropriately taught, like the side effects or what to look out for. Medication may have been titrated too quickly. So people might have, had negative prior experiences, is what I'm saying. And this can happen for multiple reasons, right? It's like some clinics are only doing 5-minute medication checks. And so you're really walking in and it's just like, okay, you're still feeling depressed. Here's a higher dose. And side effects just don't go managed or addressed. And then patients feel dismissed and they don't want to go through that again. But I think you guys as well, being in, the other side of it with the psychotherapy part, I'm sure you guys have that conversation too, because a lot of those referrals come from therapists to me. And so, like, how do you guys address that? Like, Jim, I know you probably have these conversations all the time. Like, hey, I think now it's time for you to see a psychiatrist for meds. What do you hear from them?
Wow. Well, it can go the gamut. But I would say typically people are open to it, and then more recently, I would say there seems to be more access to like psychiatric meds and people who are prescribing them, which I really appreciate, because there had been a time a few years ago when it was hard to find anybody to take on a new patient. I've, there is some of that stigma still attached with some people. But if you frame it kind of like what you were saying, Talha, about, it's a help. You don't have to be on it forever. It doesn't make you weak. There's For me, I would talk to people about the biological part of their system that, I can't really address. I can address the environment and, the family dynamics and their history and trauma, but I can't address some of that biological stuff. And so when I separate it out like that, people are generally open to giving it a try. That's what I'd say. Yeah.
Does that, but they're already coming in for the mental health treatment with that. So that is
right.
Would that be kind of a different situation?
To go from psychotherapy to meds?
Well, it's kind of like getting them into one of the mental health or psychotherapy or psychiatry, getting them into at least one where it's like acknowledgement of something that they want to work on.
Right.
Therefore getting, being willing to ask for help.
Yeah. I think, gosh, what could I say about that? When I get stuck, that's when I'll bring it up. Or, when one of my clients is stuck and it's going on, and it's like, well, what other options do we have? And I might bring up some other treatment options, like EMDR, hypnosis at times, or should we try medication? And typically, I would say that seems to work with them once they're in the system, and people want relief, like what you were saying. It's how do we get some more relief?
Mm-hmm.
So yeah, which is about healthier living. And I'm just wondering, are there any other tricks you may use, Tala, in encouraging people to utilize the resources available, like medications and any other resources?
Yeah. Well, I think, like you said, I'd like to meet people where they're at and where they want to be. And for a lot of people, medication isn't something they're interested in. And those people often still engage with me and say, hey, I still want to understand what it is that I'm struggling with.
Okay.
And I'd had, multiple patients who we would sit down and have multiple sessions and go over what their symptoms look like so we can really clearly identify what's going on. And there's multiple, moments where I say, hey, you know what? Like, this seems like it's really more psychosocial, and I want you to learn some really good coping skills and strategies here. And I honestly don't think medication's appropriate. Let's get you set up with a therapist. And there's moments where I'll do therapy with them and I'll say, hey, we can do some basic supportive psychotherapy. Maybe we'll dive into some CBT, maybe some psychodynamic, but my training in that is limited compared to a therapist. And so I'd say, hey, we've been working at this for a little while. I think I'm out of ideas here in terms of like the resources, but my therapist colleagues have a lot more, coping skills and things that they can teach you. Let's have you go there. And then if in 6 months you still feel like, hey, this isn't really working, my symptoms aren't going away, we revisit and say, okay, maybe it is time for medication.
And so, for the therapists out there listening, and I know, my dad had a few tricks or points that he gets to that you mentioned there, Dad. What are some other ways that they could help reduce the stigma of medication and have their clients feel safer about the medication options that you're discussing or that they're discussing? Yeah.
Well, I think, one of the things that Jim brought up is people want relief. And so a lot of these people have waited so long to get help, right? And there's years of functional decline, relationship stress, academic or employment issues, and early treatment just prevents so much suffering. And it's like that stigma that keeps people stuck in silence. So what I often hear is, I wish I hadn't waited this long when they came and they got treatment, whether it's from a psychiatrist or a therapist. But I think if we're looking at medication and how a therapist can help reduce that stigma, I'd say, normalizing medication as one tool, not as a last resort. I think for a lot of people, it often looks like a last resort, like, okay, nothing else has worked. Now I have to go on medication. And this is just actually one tool in our toolbox. and then helping clients prepare questions for the psychiatrist. So it's like, what should I know? What should I ask? I'm not familiar with how these medications work. Well, how often am I supposed to take them? How long? What are the side effects like? So they know what to ask and they can get their questions answered. And then one of the other big things I tell people is that medication is something you do in combination with therapy, and it enhances it. It doesn't replace the work you're doing. So it's a collaborative approach. We're all working together. And patients, when they hear that their therapist and their psychiatrists are collaborating and they're in constant communication, they love that because they feel like, okay, there's a team behind me, and my doctor understands what's going on, so he can make medication adjustments accordingly, and my therapist knows what's going on here, and he can help me through this. And that combination is just superb. I mean, like, nothing's better than a combination like that. Like, when I hear patients tell me, "Oh my God, I didn't know you spoke to my therapist. My other psychiatrist didn't." I'm like, "Well, you signed a release of information. That's what our goal is." And so
Right.
it really creates that, concrete foundation for them to feel entrusted in their care with you and their therapist. So I think a lot of that's going to really work towards getting them the help that they need.
Yeah. Yeah. I, I have a few thoughts here.
Oh, yeah.
I'm just thinking, so so the collaboration with a therapist, that's really important. And yeah, and I think maybe we'll get to this a little later, but what was coming up for me is, okay, so how often would you say that it's helpful, to be in communication with the therapist, you as a psychiatrist? Yeah, what's the most helpful way to do that, to collaborate?
Yeah, I think the best case scenario would be that the psychiatrist and therapist are in the same practice, right? And they
Ah,
find each other in the hallway and they have a conversation, and they're like, "Hey, so and so is doing so well. I just saw them. Looks like, the EMDR has really worked, and then they're sleeping better with this medication." That's the best case scenario, right? But when there's multiple practices, people are going across town to see different individuals for their care, that can be a bit more challenging. And so when you have a therapist and a psychiatrist who are easily accessible, it's like, "Hey, call my number, leave me a message, give me a time frame when I can
okay.
call you back. I will call you back." And that happens very regularly in my practice, where I'm just like dropping voicemails and then I hear back, I try to pick up, and we can often usually figure out a time to connect.
Mhm.
Sometimes if we have a HIPAA compliant email service, then we can do it that way, and a quick message in a HIPAA compliant manner can be really helpful also. So whatever is convenient, I think frequency is important too. I would try to do it after every visit. Sometimes that's not realistic if I'm seeing people more regularly as a psychiatrist, but every 3 months when I see my patients, I think that's a good ballpark for me to reach out. It's harder for therapists who are often seeing people twice a week or once every two
Hmm.
weeks. That can be a lot harder to reach out after every session. But I think a few times a year at least gives both parties an understanding of the direction that their care is headed.
Okay, yeah.
Is that a pretty typical cadence for you, around the 3-month period?
So what I generally tend to do is my first evaluation is my longer one, 60 to 90 minutes. And I tend to see people within 1 month if it's not highly acute of a condition. And so I would say our first follow up is in a month, and I'll do monthly follow ups until they're feeling better. Their symptoms are starting to reduce, their functioning is improving. Then we go to every 3 months, and I keep
Mhm.
people at every 3 months kind of through the year, just because I think a lot can happen in 3 months. For some of my more acute patients, I tend to see them in 2 weeks after the first encounter, just so
Hmm.
I make sure that they're not having too many side effects, make sure that the acuity hasn't gone up, that they need a higher level of care, such as like an IOP, a PHP, or even inpatient psychiatric hospitalization.
Okay. Yeah. So you, I think this relates to what you mentioned as like medication optimization and consolidation. Can you speak a little bit more to that, Tala?
Absolutely. And this is one of my favorite topics because, you know, being in private practice, I take over care for a lot of folks, and a lot of them come from different kinds of clinics. And what I often see is those shorter med management appointments. It's just a lot of, I have this symptom, okay, here's this medication. Or you have this symptoms, here's another medication. And I've had people come to me on 8 or 10 psychotropic medications, and I'm like, what are we trying to address here? Like, you have a medication because you're too tired and you want a stimulant, and then now you're too anxious, so you're on an anxiolytic, and then you can't sleep at night, so here's a sedative. And so for me, it means cleaning up the medication list, right? It means like really understanding that first concept, right? Diagnostic clarity, right? It's like, if we don't know what we're treating, we're just going to keep adding meds to different symptoms. But if we understand the diagnosis, we can optimize those medications, pull those 5, 6 psychiatric meds down to 1 or 2, maybe none, depending on what's going on. And consolidation itself is just reducing redundancy. Like I said, right? You're feeling anxious, so here's this. Now you're too tired, so here's something to wake you up. And then you keep going back and forth. The goal of medication management is simplicity, safety, and effectiveness. So fewer meds, better results, less side effects. I think that's the biggest goal here. And so my goal at the end of the day is like, hey, I want the minimal amount of side effects, the minimal drug interactions. And if that means sitting with you, going through your meds, figuring out what's worked over the years, what hasn't, and really figuring out, okay, which one of these is useful, that's time well spent.
How, and I've seen it before with, it's kind of the flagellation of medications when there's multiple people prescribing or just other situations like that. So how often do you see that? How often do you find yourself in a place where it's like, we need to consolidate here. This is, we're just throwing stuff at the symptoms.
Yeah, I think, it can be challenging at times when people will have a primary care doctor who's also managing their meds, and then a psychiatrist, and then maybe they see a pain specialist, and then maybe a neurologist. So they have different conditions that they're trying to address. But oftentimes some of these medications can interact with each other, or there's certain medications that can help with pain and they can help with depression. So it's like, hey, why are we on these 2 medications? Let's consolidate it to one. So for example, a medication called duloxetine, a very common medication for anxiety, depression, but also very commonly used for nerve pain. And so a lot of the times, if there's somebody with peripheral neuropathy from their diabetes, we'll have a conversation with the neurologist and say, hey, what do you think? I'd hate to have him on this medication for depression and anxiety and something else for this. Can we use one and target both of the symptoms? And oftentimes we agree on that, and patients do really well. And so now it's not 3 medications, it's still the one.
Oh, okay. That's fantastic. Yeah. Well, switching gears to some of the treating addictions and some of that work that you've done, opioid use, alcohol use, others. What role do medications play in the addiction side of the sphere here?
Yeah. Like you were joking, the triple board certification. I mean, it's one of those things. I got into addiction psychiatry, did the fellowship, and then addiction medicine is another tool. And I felt that, hey, let's go in that direction too. Make sure, when we're addressing this, I have all the tools that I can have to offer support to my patients. And so with that, I'm a big advocate for medications for addiction treatment. I think they're life-saving at the end of the day. For opioid use disorder, medications like buprenorphine and methadone, they reduce mortality by over 50% at times. And, for alcohol use disorder, medications can reduce cravings. So patients can, engage in therapy, go to AA. Limiting alcohol intake, prolongs their life. It prevents further liver disease and the risks of other, medical conditions. So not only are we treating addiction, but we're also treating a lot of the medical complications that can arise from it. So yes, like the risk of overdose will go down, and the risk of, a DUI or, a fatal accident or whatnot, but also everything long-term down, from there, you're going to help these people long-term. So what I always tell people is, like, if we can get people into substance use treatment, get them on some medication, they're going to be able to go on and live really great, healthy lives. And I will say, medication doesn't replace recovery work by any means. It stabilizes the brain chemistry, so recovery becomes achievable at the end of the day. And so we want to address cravings. We want to address withdrawal. We want to address something called post-acute withdrawal syndrome, even, which is pause. And that is something that people tell me, they struggle with for months or years after becoming sober. And so if we're not addressing these symptoms, the likelihood of them relapsing is a lot higher. And then the risk of death from that, it just skyrockets.
Yeah. so I'm trying to think. So actually, here we go again. I keep coming back to some of the most chronic pain patients. Okay, and I see a number of the people who suffer from chronic pain who used to be on opioids, and it's really switched now, and they're a lot of times they're on like the medical marijuana for that, which seems to help. And I guess I'm just wondering what your thoughts are about that, from going from opioid use to medical marijuana. And yeah.
Well, I think if you ask a classroom or a building full of psychiatrists, you're only going to get a handful of them that will raise their hand to say yes to medical marijuana. The majority of psychiatrists feel medical marijuana doesn't really have much benefit. The evidence of marijuana use worsening depression, worsening anxiety, causing psychosis, early onset schizophrenia is vast. And so from the literature, the evidence is showing us that marijuana really is not the direction we should be going. And there is a lot of butting heads between different fields right now in regards to that. And, it's challenging because I see that a lot in my practice where people are coming to me on medical marijuana, but then they're having worsening anxiety, or they're having panic attacks, or they've even developed psychosis and landed in the ER. And they still feel like the medical marijuana wasn't the reason for that, when very clearly they had no other substance use going on. There's no other reason for this. And when they stopped using the marijuana, the symptoms went away. So I have multiple patients who were using marijuana multiple times a week, and they reduced to once a week or once a month, and their anxiety got better, their depression got better. They no longer had some of the psychosis that they were experiencing. So my opinion is on medical marijuana is it's not something that I advocate for or recommend. But I think there's people out there who, may not agree with that.
Okay. So how do you, so if I go to the chronic pain folks and like as a therapist, when I see people who are suffering from these chronic pain or chronic mental illness, it's like, to me, one of my goals is to, or a basic goal is to just maintain, their level of adjustment, hopefully improve it a little bit if I can, and then hope that it doesn't get a whole lot worse. And I'm using hope quite a bit here. So, but I mean, from your perspective, Talha, is that, I guess I'd call it maintenance in a way, maintenance and support, and trying to avoid people getting into a higher level of care. I'm not sure what my question is, but how medications play a part of that, and I'm hearing you fairly loudly and clearly say medical marijuana is probably not the way to go. So
yeah, I definitely say that, if I had to recommend anything when it comes to an individual who had an opioid abuse concern, and an addiction to opioids, buprenorphine is great. It treats pain, it treats cravings, it prevents withdrawal, and it reduces overdose risk significantly. Methadone also does the same. Methadone is just a little bit more complicated. Suboxone, you can take home with you and you kind of dispense it to yourself. Whereas methadone, you have to go to a methadone clinic every day, stand in line early in the morning. After months of successful treatment in a methadone clinic, they may give you take-home supplies of it. But if you're looking at the science of it, the risk of overdosing on methadone can still happen. That's why they don't give you it to go home unless you have been very consistently in care. Whereas with buprenorphine or Suboxone, which is the brand name, the risk of overdose is a lot less. And so they're comfortable sending that home. And so what I would say to that is, it is very common for people to jump from one addiction to another. And so if you have someone who's, recovering from opioid use, they often switch to cannabis, or they switch to nicotine, or they switch to caffeine, for example. So it's one of those things that dopamine pathway is constantly getting activated, and people who struggled with addictions, that's what they are seeking. And so they will find a way to seek that sort of reward. And we have to work with medications to help reduce that sensation.
Okay. Oh, well, okay. So looking at that, treating addiction, and I guess speaking to the partnership between therapist or addiction counselor and psychiatrist, I mean, is that collaboration any different from what you were talking about before, and the communication piece, and how is it, if so?
I think it's pretty similar, right? I think the collaboration needs to be there no matter what it is that you're treating. I think when it comes to open communication, our lines should be available for our colleagues. So a quick text, a shared note, a 5-minute call, they make a huge difference. The therapists, they help patient build structure in their lives, create accountability and the emotional insight to understand what they're going through and what they need. A lot of the motivational interviewing techniques that we utilize are really important. They're like, hey, what is it that you want to achieve out of life? And what are your goals? And is your current substance use in line with that? Is that going to get you to your destination or not? And so working on those is going to be really important. And then as the addiction psychiatrist, I'll do a lot of the motivational interviewing, but my biggest, tool I have is the medications that help stabilize withdrawal. They reduce cravings, and we can also treat the co-occurring mental health concerns that often go with addiction. So that way, we can help them from all directions, right? It's a shared mission at the end of the day. Neither of us can do it alone. AA, NA, sponsors, LADCs, like we're all in this together, and we're all a big team to help people get sober, stay sober, and, continue to live great lives.
Yeah. So I want to switch gears a little bit here, and I've really appreciated your discussion here on the addiction side of things. For the therapists and the kind of the practical realities for behavioral health practices. Um, you know, can we talk about the different types of prescribers that there are, MDs, DOs, PAs, which I mentioned earlier, along with nurse practitioners, prescribing psychologists. So for anyone who kind of gets lost in those distinctions, what's the simplest way to understand, who is doing what, who can prescribe what?
Yeah. So I'll start off with just myself, just because I know where I came from, and so it's easier to talk about. As an MD or a DO, as a physician, your background is in medicine, and so you've done medical school, you've gone off and done a residency afterwards, and so your medical school is 4 years where you are learning everything from biochemistry, physiology, anatomy, pharmacology, and then you're going into everything like obstetrics, gynecology, you're going into surgery, you're going into all of these things. So even as a psychiatrist myself, as a medical student, I've removed gallbladders, I've, helped with other surgeries, I've delivered babies. And these are all things that every psychiatrist, whether you're an MD or a DO, you have to go through. And so you understand a lot of the medical part that goes on. And so when my patients come to me on these other medications or other conditions, or even when I'm evaluating, I have that background. And so I can use that to know where to refer and how to do, different things there. And so when I then finished medical school, you go on to do a residency, and a psychiatry residency is 4 years, in which you do a year where you're doing neurology. So you learn to identify strokes and Parkinson's disease and Alzheimer's and treat those things as well. And then you do medicine. So you're on the medical floors, you're managing all the different medical conditions that come in. So you get that exposure. And then in your final 3 years of residency, it's a lot more psychiatric based, where you're learning a lot of the medication management for people on an inpatient psychiatric unit, outpatient in the clinic. And then you're also expected to learn therapy competencies. So you have therapists, usually LCSWs, who evaluate you and they monitor your therapy. So we get trained in supportive psychotherapy, CBT, a little bit of DBT, psychodynamic psychotherapy. And then beyond residency, you can go on and do further fellowships if you'd like. So there's child adolescent fellowships, addiction fellowship, geriatric, consult liaison, and then also forensics. And then there's more. You can do therapy fellowships as well. So people go, do psychodynamic fellowships and things of that nature. So as an MD or a DO, you are trained in both medication management and in psychotherapy, and you utilize it how you want. And then beyond that, you have multiple other kinds of individuals in the healthcare field, NPs and PAs. These individuals can also prescribe medications, and some of them do therapy as well, depending on the training that they've received. And so there are some residencies and fellowships out there for nurse practitioners and physician assistants. And so they can gain a lot of exposure in these conditions as well and how to treat them. So they are also really good options because right now there is a shortage of psychiatrists. And so if you're not able to get into one, there are multiple other people who can continue to help, assist you, treat you. And then oftentimes, hey, say, you know what, maybe we need you to see a psychiatrist. And then they refer them to us if it's out of their, comfort zone. The biggest thing I'll share, though, is, primary care physicians, right? They also, they went to medical school. They've learned a lot of this as well. But they're the front lines, right? When you go see your doctor for your follow-up and they say, hey, how have things been for you today? They're going to ask you about like, hey, are you having any sort of depression? Are you having any sort of anxiety, any sort of suicidal thoughts? They're that first line screen there to evaluate that. And they often start medications for us. I'd say, like 30-40% of psychotropic medications are probably started by family medicine physicians because they're that front line. And they will often treat up to their comfort level and then refer to us from there. And then when it comes to psychologists, some states have given prescribing privileges to psychologists as well. That doesn't mean you can just open up and start prescribing. They do have to go to 2 years of schooling further in physiology, anatomy, and pharmacology to better understand the medication. So they also get pretty well versed in what the medications are, what the side effects are, so that they can be licensed to prescribe those. So there's multiple people here, at this time where mental health access is limited. The opportunity to have more people assist our patients is invaluable, and so if we can continue to have multiple people here on the forefront being able to help, I think that's great.
Yeah, I know that's been helpful in my referring people, for a medication eval. And maybe this is my bias a little bit, but it's nice to have a place to go where someone there's consultation about medication, or I won't call it supervision necessarily, but where the psychiatric folks are talking to each other about what might be the best med. So yeah, but it's good having some more resources.
Yeah.
So Talha, can you give us, and you've somewhat done this already, but I'm wondering about a high level overview for therapists about different meds and what they're used for, and things like SSRIs and mood stabilizers or the antipsychotics. Yeah. Do you know what I'm asking here about, just a broad overview for some psychotherapist here? Yeah.
Crash course on the alphabet soup.
Yeah. Yeah.
I like that. The alphabet soup. No, absolutely. I think there's just so many medications out there and, it can get really confusing at times, but what I'll say is we'll start with depression, anxiety, PTSD, OCD, things of that nature. These are usually treated by the SSRIs or the SNRIs. These are the gold standard kind of medications. The SSRIs are going to include medications like sertraline, fluoxetine, escitalopram, which are the generics for like Zoloft, Prozac, Lexapro, things of that nature. And then the SNRIs also treat very similar conditions. Those are going to be duloxetine, venlafaxine, generics for Cymbalta and Effexor. And these medications are pretty well tolerated. We tend to start with the SSRIs because they have more research behind them. They've been around a lot longer. They have less side effects. And usually we'll try out a few of these, see if they work. If they don't, then we'll transition over to SNRIs. And then if SNRIs don't work, we have multiple other kinds of medications for those conditions like TCAs or tricyclic antidepressants, and then MAOIs. And these are even older medications and they have a lot more side effects, but they're not used as frequently anymore. But we do have those in our back pocket in case we needed them. And then for conditions like bipolar or other mood conditions where we're unclear, is this bipolar or just a mood disorder, cyclothymia, something along those lines, mood stabilizers like lithium, Depakote, lamotrigine, topiramate, these are all really good options as well. These medications can be life-changing for people, especially with like bipolar disorder. Lithium and Depakote, they can have people living really functional lives. And, they do require some monitoring. These medications aren't without side effects. So we check labs all the time. We make sure we get levels of lithium and of Depakote just to make sure we're not, in a toxic range. So these medications are helpful, but, we have to be really careful with them. And then you have your conditions like bipolar or psychotic conditions or medications for like adjunct for severe depression, where we're going to use more antipsychotics. So medications you might see commercials for sometimes, like aripiprazole, lorazepam. These are like generics for Abilify or Latuda. By augmenting, we mean they're just going to make the antidepressants work a little bit better or in combination to really treat your depression and lift you out of it. So we usually augment if we're feeling like, okay, some of your antidepressants aren't working to their optimum. Let's add a little bit of this antipsychotic. And I feel like that term itself is a concern for a lot of people because they are like, I'm not psychotic. I don't need to be on an antipsychotic. And so there has been some push to rename that field or that medication in the field. But right now it's just what we've been used to calling it. So we haven't changed it yet, especially since a lot of them are used for more of that psychotic syndromes like schizophrenia or schizoaffective disorder. But other medications like risperidone, haloperidol, these medications, they tend to do a really good job for people with schizophrenia, right? And they have long-acting injectable versions as well for some of these. So people can get a monthly shot. There's shots that can go up to every 3 months or even every 6 months. So for some of our folks who are like, hey, I understand these medications help me. I don't like taking a pill every day. They can come and get these shots and they, do really well on some of these. So some really good resources there for bipolar and schizophrenic conditions. And then when we're looking at stimulants, and there's some non-stimulant medications used for ADHD, things like methylphenidate, and then amphetamines. These are like your Adderalls and your Ritalins. These do really well to address ADHD. These are controlled substances, so you do have to be really careful with prescribing those medications. They can be abused. There are non-stimulant options for ADHD as well, things like atomoxetine, clonidine, and guanfacine. I tend to use those a lot for a lot of my telehealth patients when I can't see them in person. The DEA does require you to see people in person for controlled substances. So we try to provide patients care, for certain conditions, even if they're only seeing us by telehealth, saying, we know that these stimulants are probably the gold standard and they would probably work better. But right now, because you're in a different state, I can't prescribe that. But if you want, you can see someone locally and try those, or we can try some of these alternatives. They have less side effects at times, and they're less likely to be abused. So I have a lot of people who will vouch for those medications and say, hey, those medications work great for me. I don't ever want to be on a stimulant. Just depends on the individual. And then when it comes to alcohol and opioid use disorder, your anti-craving medications, like we talked about, buprenorphine, methadone for opioids. And then you have medications now for alcohol, like naltrexone. Naltrexone reduces the number of drinking days a week, and it decreases the number of drinks on a drinking day. And it comes in a monthly injectable form as well. So I often use that for my patients who are trying to maintain sobriety. And we have some medications now that are also helpful for methamphetamine abuse and stimulant abuse, so we can use those to reduce cravings. And there are some medications in the works that we try to use for cannabis abuse as well. So we have a lot of different medications that we are studying right now, and then some that are still being tested. So hopefully in the near future, we'll have even more tools to address addictions. But each category targets specific neurotransmitters, specific pathways, and matching those symptoms to the right class is key, and making sure that, we, like I said, have that diagnostic clarity so we can make sure we're treating you appropriately, because certain medications may make certain conditions worse.
Huh. Well, I'm curious. You talked a little bit about there's new meds that are coming out. Is there anything else that you're seeing that looks promising for other aspects of behavioral health, or anything, or anything just for any of these, what we've discussed today?
Well, I mean, I think there's a lot of literature and studies going on for a lot of our Alzheimer's conditions as well. Psychiatrists will often get called to address that. So there are new medications that are actually targeted to attack the protein that is thought to cause Alzheimer's, and so slowing the progression of that even more so than some of the medications we currently have. So we're really excited about that. And then there are some more antipsychotics that are coming out that are hopefully going to have less side effects, because some of these antipsychotics, unfortunately, can cause weight gain, increased cholesterol, diabetes risk. So they're really trying to find medications that can make sure that they don't have those side effects. So, because in my experience, I've seen people gain, depending on the medication, 10, 15, 20 pounds, if not more. And so we really have to be cautious of what we're prescribing with what individual. And so if we can get medications that have less side effects, that'd be great. And they're really working on that right now.
Cool. All right. What about pharmacogenetic testing? And that's kind of been a buzzword lately. I don't know if I'm pronouncing that right, but what do you know about that?
So pharmacogenetic testing, I mean, it's a helpful tool, but it's not a crystal ball. And unfortunately, I've seen it being marketed by a lot of people in practice, saying that, hey, all of your evaluations will include pharmacogenetic testing. And that's what we do at our first visit every time. And I don't necessarily think that's appropriate. And the American Psychiatric Association has agreed that they don't feel it's appropriate either. And the reason for that is the test itself cannot tell us which medication will work specifically for the patient. What it does is it helps us understand why someone may have failed multiple medications, why they may have too many side effects to certain medications. And so a little bit about what the pharmacogenetic testing offers is each individual is born with, certain enzymes that metabolize these medications. And so when you take a medication, it has to get metabolized through a certain pathway in our body. And I may have, say, 100% of the enzymes compared to like the general public. And so I metabolize a medication at the same rate that majority of the people in the study did when they tested this medication. And so for those individuals, the current dosing regimen is appropriate. Now I might have patient B who has a high number of these enzymes. So instead of 100%, they have like 200% of these enzymes. They metabolize these medications a lot quicker. And so they may say, hey, I'm at the 200 milligrams of this medication, and this is the highest dose that is recognized right now by the FDA, and why is it not working for me? And what we do is we end up having to go higher, and we see a result, and we're like, that's strange, because most people respond at 200. You might be a rapid metabolizer. That's why you need a higher dose, because it gets out of your system quicker.
Okay.
And then you have patient C who is like, hey, I'm on the starting dose, but I'm feeling a lot of side effects right now. And we would go down on the dose even more. So some of our medications, say the lowest dose is 10, and we're like, okay, this is where we're going to start you. And you're having side effects as if I had started you at 20. That makes me a little concerned, like, okay, is this building up in your body? And so you may only have 50% of the enzymes. And so now that 10 milligram is building up so much in your system, you're getting side effects. So we have to pull you down to 5. And a lot of this we know that we can do just by asking these questions. Now, what often happens is if I've tried multiple medications in the same family and I keep seeing that you're getting side effects or that you need higher doses, that makes me feel like, okay, maybe we should get testing done to see, are you a rapid metabolizer or are you a slow metabolizer? So we can optimize the dosing of your medication. The test will not tell us which medication will work best. It will say you metabolize medications in column A the same as majority of the population, or you don't metabolize these appropriately. You metabolize them slower, so you should be on a lower dose, or you metabolize these quicker and you need a higher dose. So that's all it will tell us. There is one other part to that test called a serotonin receptor test. And that can sometimes be helpful if they've failed multiple SSRIs where these serotonin molecules are supposed to work. And that might tell us, okay, maybe SSRIs are not the family of medications for you, but that doesn't mean that it will tell us which of the other families, which medication we should grab from the other family and try. And I think that's the unfortunate part in psychiatry, because in multiple other healthcare fields, like infectious disease, for example, we can do a quick test on the bacteria that we find in the urine culture and say, this is what this bacteria is susceptible to, and this is the antibiotic we're going to start, and you will have a resolution in 5 to 7 days of antibiotics. Or, this medication has been shown to help with blood pressure. Majority of people do. We don't have that, unfortunately, where we can run a quick test and say, this is the medication for you. And that can be frustrating for a lot of people. And that's why I understand a lot of people really want pharmacogenetic testing to be the answer, because they want answers like we have for other healthcare fields, which we don't yet for us. And so I try to explain that to my patients. It is an expensive test. I hate to have people spend money on something that's not going to give us a lot of results right off the bat. But if we feel like things aren't going well, then I might order it and say, hey, let's get some clarification on what's going
on. Okay. Yeah.
Good to clarify.
Definitely. Yeah. And I can see where it'd be helpful that it's not the magic pill, so to speak, so here's the magic cure.
Oh, he doesn't tell us what's the magic pill. Yeah.
Yeah, for sure. Oh, well, is there, do you have some thoughts on when a therapist should refer, to their primary care physician versus a psychiatrist? Like what as a therapist, what should I be looking for and going, okay, and I'm thinking complexity is one of the things, but it's like, any other thoughts about that?
Yeah. I'd say that when it comes to who you want managing the condition is on complexity. I think that's very valid. And I also think the other part is how quickly can someone get in to be seen? And so in a lot of communities, it can be a 6-month wait to see a psychiatrist. So if you can get them to see their PCP in a month, you might get them started on a medication in that time, and they're not waiting to get into a psychiatrist. They can still make that appointment. And then when we see them, we can say, okay, the PCP did a great job. They started you on the right medication, but let's titrate your dose up a little bit, or let's tweak this medication. Maybe you would benefit from this because you've been on it for a few months. But I think getting people to care is really important. The big things I'd say is, more straightforward depression, anxiety, things of that nature, primary care does really great with. And most of the times when I see primary care referring to me, it's usually like, hey, this depression hasn't cleared. They're on a good dose of the medication. I'm getting a little nervous. Can you kind of help us? And we do collaborative models as well, where sometimes the PCP will just reach out to us and say, hey, can you give us some advice here? And that collaborative approach can be really helpful. But sometimes they'll just refer them to us. But if you're getting to a place where the depression is more severe, maybe treatment resistant, maybe there's self-harm, suicidal thoughts or suicide attempts, then that's maybe a point where it's like, okay, we need to see a psychiatrist or a higher level of care, like going to the emergency department. Or if there's a lot of diagnostic uncertainty, if we're like, okay, I'm not really quite sure if this is a bipolar 1, bipolar 2, is this a cyclothymia? Is this just an adjustment disorder? Is this substance-induced psychosis, or is this schizophrenia? That's when it's really good to have a psychiatrist lay eyes on them to do a more detailed assessment. And then when multiple medications are involved, so if you're seeing a patient who is already seeing a primary care doctor and they have tried multiple medications, it may not be a great idea to send them back there because it seems like, okay, they've tried a bunch of things. Maybe we should have a psychiatrist take a look. But the big thing for me is safety and timeliness. And so if we feel like safety is a concern or they're not going to get in, we have to triage accordingly. So if we can get someone to see their PCP and they're not high risk, I think that's great. If they're higher risk, get them to a psychiatrist. If anything else, go to the emergency department. I think that's a really safe bet. And I think as therapists, being very familiar with the DSM criteria, mild, moderate, severe depression, different things like that, you can also gauge how well a patient is functioning, and so based off of that, it may be a really good way to say, hey, like, okay, you're not functioning really well right now. You've missed a lot of work. You're struggling with taking care of yourself. Maybe we need to get you to see that psychiatrist now. So it can, I think it's all individualized and everyone's a little bit different, but I think those key kind of criteria we touched on would be helpful.
Yeah.
So you talk about the emergency room a little bit. Are there any other situations where you'd recommend, this we can't get you into your primary, we can't get you into a psychiatrist. It's time for the emergency room.
Yeah, I mean, I think safety is the big thing there, right? Self-harm, suicidal intent, suicidal acts, also like hallucinations that may be command in nature, so by that we mean these voices that sometimes people hear in psychosis that can tell them to hurt themselves or hurt others, even if they haven't acted on them yet. But if they're having these command hallucinations, it'd be a good idea for them to be seen in the ER. When it comes to substance use, if they're going through severe withdrawal, one of the big things I want to emphasize here is that alcohol withdrawal and benzodiazepine withdrawal can be life-threatening. People can die when they're withdrawing from these. They can have seizures. And so those are really important times when they need to be seen in an emergency department and usually admitted on a medical floor to make sure that their withdrawal goes in a safe manner. And then when there's inability to care for basic needs, so if people aren't eating, if they're unable to maintain hygiene, that may be a really good reason for them to go to the emergency department. And then from there, triage to inpatient psychiatry, or depending on what the ER psychiatrist recommends.
Okay. Yeah. Well, okay. The other treatment modality that has really come around since COVID is telehealth. And I know it's transformed my practice, and I'm still probably about 50-50 in seeing people in telehealth and then seeing people in person. I guess I'm wondering how do you see it affecting the access to psychiatric care, and then coming up, with the new Medicare laws coming out, and what I'm really for telehealth and how it's helped people stay in touch. And even when people have to cancel because something, they get a flat tire or something, they can still do a telehealth session, and that has proven really helpful for me. The other thing I'm thinking about is the rural, with my practice out in Glencoe, seeing people through telehealth in the rural community has been really helpful. So, yeah, just some comments about that, Talha.
I mean, I think telehealth has changed the game. I think it's increased access significantly. Rural communities, like you said, busy parents, people without transportation, people who are incarcerated. So many people have now gotten access to psychiatric care because of telehealth. And like you said, right? Like life happens, you get a flat tire, you miss an appointment, and now you're, out a couple of weeks till your next appointment. Whereas telehealth, you can just pick up the phone, get on your laptop and log on and have a conversation. It's reduced no shows. It's increased, follow through and compliance, and continuity of care has, improved significantly like I've never seen before. And so, I think when I started my practice, it was solely telehealth, and that was during COVID. So it was really beneficial for a lot of my folks. And I have a lot of people who suffer from conditions like agoraphobia, for example, who really struggle to get out of the house or, be in a clinic setting where they're surrounded by other people and they get really nervous. And so to be able to address conditions like that in the comfort of their own home and then make little baby steps to, get them out of the house in that safe environment, you're providing care to people who wouldn't have otherwise even come to see you because they're so afraid to get out of the house or show up in a doctor's office or a therapist's office.
Right.
And then like you mentioned, with the laws changing, it's really unfortunate. And this is where I think like mental health workers, whether you're psychiatrist, therapist, advocacy is really important, and being, at the state capitol when you can for advocacy days, because we really need to tell our lawmakers that like telehealth is improving access to care and it's getting people the care that they need. And, if we take that away, a lot of people are going to lose access to care. Now, in psychiatry, right, our patients, they may stop coming. They may, stop taking medications. They may have too much anxiety, whatnot, to be able to be seen. And so like, what's going to happen, right? Those rural patients, those disabled patients, those parents without childcare, it's just creating unnecessary barriers to get access to care. And, not even just in mental health. I'll give an example of my wife, who's a pulmonologist. And so she has a lot of people who do telehealth with her as well. And they come from rural Minnesota, where if they were to drive to her clinic to see her, it would be an hour and a half drive there, an hour and a half drive back. And these aren't people who can afford the gas to do that, let alone afford the medications, like the inhalers that they need. So if they're struggling to afford, the $80 inhaler, how are they supposed to afford the gas to go there and back for their appointment? So they're just going to stop coming as well. So this isn't just a mental health issue, it's healthcare in general. We're getting access to care to these people who, would otherwise not get the care that they need. So I think we really need to advocate for that. Telehealth is great. I am all for it, and I try to use it for my patients. And there's a lot who, want to be seen in person. And I do think there's a big benefit to in-person visits as well, right? Because that connection is there, and I do enjoy that. So my patients have the option of doing either or. And, we do a mix at times. If they're here in Minnesota, some, every other visit or so, some of them will come in person just because they just wanted to say, hey.
Okay. What about some of the CMS's telehealth law? And I know on the behavioral health or the outpatient side, at least, that it's, we got, especially with Medicare, you need to see somebody in person once per year. Is that the same in psychiatry? Are you, and how's that affecting your patients?
Yeah. So I just had a situation today where, because I'm licensed in Illinois and I was seeing people there before I moved to Minnesota, and I have some Medicare folks there who want to continue care with me. And now with this change of having to be seen in person at least once a year, we're trying to navigate how we're going to do that. And that, that's quite challenging. And that's, where co-working spaces come in handy. So, one of the things I'm going to share is, I think we had talked about on the last episode where I got the idea for Mindful Spaces was a similar place in the Chicagoland area. And that's where I might go back and say, hey, I need one day once a year, and I will get all my Medicare patients and see them that day, and then make sure that I can see them online after that. Like, if that's the way we have to go, that's the way we have to go, because I would hate to abandon somebody and say, hey, you need to find a new psychiatrist just because of this. It's unfair that, patients are going to suffer from this. And I think that if we raise those concerns, hopefully, CMS will change some of this, but we have workarounds if we have to. And, I'll be using that co-working space in Chicago to do that.
Sounds about right. Yeah.
What about parity? And how, the lack of parity that you might see, and how providers, a lot of them, and even some previous therapists that, they've moved to cash pay only. You and I talked a little bit about what concierge medicine, um, and all of that, unless you have the cash, can be restrictive to access. So are there changes that you would like to see policy-wise, to keep that access going?
Absolutely. I mean, I think if we just look at the healthcare environment at the moment and just kind of what's going on with the major insurance carriers and the record profits that a lot of them are making while they're still increasing your annual premiums for insurance, they're increasing your deductibles, they're, increasing your copays. And so all in all, patients are feeling like, they can't afford healthcare already, even if they are insured.
Mhm.
And what's also happening is psychiatrists, therapists, our reimbursement isn't the same as others in the fields. And so when you are feeling like, one, you're not getting reimbursed what you should be, and your patients are paying more for their insurance, where is that money actually going, right? It's, very frustrating. So there have been some attempts at passing laws where a certain percentage of the money that an insurance company makes has to go into patient care, not into administrative costs. And I think as we do, more in terms of advocacy and try to create policy for that, that way we'll be able to give patients affordable care. And I think the idea of switching to cash pay is the unfortunate reality for a lot of people, because we are also in the field of business, right? Because we are trying to get food on our families' tables. And if we're feeling like we're not reimbursed for our time, well, we will charge cash, and then you can just use a super bill and submit that to your insurance, and you can get back whatever they're willing to pay you for it. And that's unfortunate, right? And I think if we look at true parity and if we can advocate for that, more people will accept insurance. More people will say, hey, we don't want to charge patients cash only or these exuberant rates. We all came into this work to support others, right? We're here to help people. And I think we would all still do that. I just think there's just too much bureaucracy and there's just a lot of stuff behind the scenes that we have no control over. So when reimbursement reflects the complexity of psychiatric care and telehealth regulations are there to prioritize access, I think, we'll be a lot happier as providers of this care. And I think our patients will feel more valued in that sense as well.
Mm-hmm. That's been parity's been a big battle on the outpatient psychotherapy side too. So definitely feel that. In some ways, things are moving a little bit, but we're also, at least at the legislative level, but also on the payer level, we're seeing more and more, if not lack of parity, at least complexity with the different copay amounts, or people getting reimbursed a little bit less for the telehealth visits. That's just starting to eke through a little bit. So it's tough when you're in a for-profit or at least high profit world, because that when it's about the money, it often you end up losing the care for the patients, and that's what we're definitely seeing on our side.
So, and just to piggyback off of that, what that ends up leading to is shorter visits, right? And so where you were seeing 10 patients in a day, now you're seeing 15, 16, just so you can make the same amount of take-home money every day. So the quality of care is unfortunately going down because you're not spending as much time with those people. So those 30-minute appointments are going to turn into 15-minute appointments. And that's just not fair to the patient. And then it causes burnout for the provider as well.
Yeah. That's the squeeze. That's the hard part, and everyone's paying for it. I know for at least a number of our customers, like they need an hour to kind of get sometimes it's the first 45 minutes is what it takes to warm into whatever the subject that they're trying to address, is what I've heard from numerous customers. And it sometimes takes an hour, and sometimes it's that last 5 minutes is where you finally hit that point where and I don't know if you've experienced this, but it can take that sometimes it takes an hour to do your job and to give the client the best care. So having payers come down saying you can only bill 908.34 for a 45-minute session,
and keeping track of that.
Okay. Just trying to dictate care,
right?
Is that's a whole nother topic.
And just the billing code thing, really quick. Sorry, there's some insurances now that are automatically down coding your billing code.
What?
Yep.
Yes. Oh, this is the first I've heard that.
You have to. Yeah, and you have to prove, you have to reach back out to them and prove that you actually should be reimbursed for the code that you build. So just because you build it doesn't mean they're going to pay it. They're going to down code it, and then you have to file an appeal.
Mm-hmm. Yeah, and or limit it to certain diagnoses as well. Definitely seen that.
Okay.
So it's a tough world.
Yeah. More and more challenging.
Which is why taking insurance is so complicated.
Yeah. I liken it to access to a market. And some of my communications that I do around building a practice is, how much of what percentage of what your revenue can you sacrifice to access a market, which is a group of people who are on a plan that you are in network with. And just like deductibles, it's getting uglier and uglier as far as the percentage that you're having to sacrifice in order to in order to see the clients in that insurance bracket. So on the on the opposite side of that, for providers looking for growth, do you have any advice from your perspective of how can psychiatry or just practice growth, what advice do you have for owners that are trying to really make a go of it?
Well, I think just back to our last visit together, the last episode, the idea of investing in relationships, right? I think that's key at the end of the day, building genuine connections, and that's with everybody, right? Like primary care physicians in your community, the OB-GYNs in your community, neurologists, emergency departments, addiction programs, anyone who touches behavioral health. And that's kind of everybody. I joke around about this because in the hospital, people who go into a field like surgery or a field like dermatology, they feel like, oh, they'll never have to deal with mental health. And I'm like, no, people with depression, people with schizophrenia, people with bipolar can still fall and hurt themselves and need to see a surgeon. You need to know the complexities of working with these individuals, and they can also develop rashes. So a dermatologist will still see them. So, having these connections, being able to find ways to support each other, because they will reach out during those complex cases and say, hey, I'm really struggling here. How can I best help my patient? And so open doors of communication, I think that's really important. Once you have that, referrals just flow naturally when people trust that you're going to take really good care of their patients, and that clinical excellence, then it kind of spreads by word of mouth. And so one, we always talk about this, take things slow, create those relationships in the community. And two, if you're in the mental health practice world, having it siloed that, psychotherapy is one silo and medication management is a separate silo is not, I'd say, optimum care, because we are doing the same work, right? Our goal is the same.
The goal.
And if we can be in the same silo, and in one practice you have a psychiatrist and you have some therapists and you have LADCs and you have these, if you can create something like that, then you get all the care in one place, and you're not trying to say, okay, well, now I need to refer you to a psychiatrist who I don't know when they have availability, or in my situation, it's like, okay, I need to know, certain therapists in the community. No, you have them in-house. And so that's also a big thing, is like, we are, when I look at big orthopedic players, right? Surgeons aren't by themselves and physical therapists aren't by themselves, although at times they are, but usually they're in the same practice, because once they have surgery, they need physical therapy. and they go hand in hand and they work together. And so we can do the same thing. And so being in the same group, growing a practice of that nature, I think is going to provide better care for patients just because they can get everything in-house.
But, relationships and that collaborative and openness to provide, and you're right about what's the goal. It's, it's to help people, heal, and the best way to do that is in a collaborative way. That's what I'm hearing you say, for sure. So, yeah.
Yeah, I think being siloed, being fragmented, I think all of that is just, not fair to patients. And so patients end up bouncing between providers, and someone needs to take the lead. Otherwise things fall through the cracks. And, if you can build a practice, that has strong cross-disciplinary relationships, patients get smoother, safer, more effective care at the end of the day. And then practices grow because, they become known as reliable partners. And so as you create those connections, you're going to watch your referrals grow and patients' care will be optimized as well.
Yeah. So you talked a little bit about just the people's lack of time, or providers' lack of time, and deductibles going up. As for providers, as they get squeezed more, or really as the necessity for high efficiency grows, some of these quick fix clinics that we've talked about, what are your concerns about this trend of just lower, shorter patient care, or the focus on the dollar?
Yeah, I mean, just like we talked about, the biggest concern over there is, right, speed over quality. And so how many patients can we see in an hour? When I first finished my training, I joined a company that was expecting us to do 10-minute medication checks and 5 minutes to do notes. So 15 minutes total per patient. And they expected you to see 4 an hour. And you can imagine in 10 minutes, I could barely complete the conversation about how their weekend was, let alone do a full evaluation on, are you having side effects? How are your symptoms? What should we do? And so it wasn't for me. And so I had to leave and, start my own practice because those 10-minute med checks, that just leads to aggressive polypharmacy like we talked about, right? Because it's like, oh, I'm not sleeping well. Here's another medication. I got to go, and then you limit the psychotherapy that you can provide as well, because I wouldn't have had time to do any supportive care or any cognitive behavioral techniques with those folks. And so we were really looking at short-term fixes, and it just led to more long-term complications, right? Because of like more medications, more side effects. So when medicine is driven by volume instead of outcomes, your patients are going to suffer, and then the trust in psychiatry itself declines. And so if we can continue to create practices that are independent, as we talked about previously, and you do what you want. My appointments personally, new evaluations are 60 to 90 minutes. My follow-ups are 30 minutes. And then if we want to do therapy, I have 45 an hour long visits with some of them as well. So because of my, the way I've created my practice, I can do that and nobody can tell me otherwise. And that's why I like it. And that's why I do it. And, I think that's what a lot of us do in private practice.
Yeah. Well, I'm going to say there's been a few times in this conversation where I've gone, if I was a new practice owner or something, I might be thinking, God, I better get out now. Okay. Yeah. However, I'm going to say this too. It's like you're providing hope. You're providing inspiration. And I don't have to work for a cookie cutter organization. I can have my own agency, and I think that's who we're speaking to for the most part here. I can have my own agency and do it my way in a creative, ethical manner, and I can still make a living doing that. And so I keep coming back to that within this conversation, and so I'm not quite ready to get out yet.
No, I don't know. Well, and you, I mean, you have to be willing to kind of fight that fight a little bit. And yes, it's gotten harder lately, but it's that independence. It's that people taking that approach, similar to what you've done here with Comprehensive Psych Solutions, is like is to do it what you feel is the right way. And those are the people we're really trying to reach out to with this podcast too, is like people who want to do it their way, which they see as the right way, so they can approach it in a manner they see fit, often influenced by past experiences similar to what you said, or who've worked for, some big box mental health or what have you. So yeah, you're definitely preaching to the choir here about that. Like, and I think our listeners hear that too.
Yeah.
Yeah. And I think, the most rewarding part of that is when a patient tells you, hey, my last doctor never asked me these questions, or they never spent that much time with me, or, they never spent this time explaining something. And they say that, like, they're going to refer, their friends to you because they're like, hey, they felt heard.
Yeah.
There's nothing more rewarding than that. And so it's like, okay, I feel like I'm making a difference. Patients feel like they're being heard. And at the end of the day, then, you do get to, make money doing something you're proud of, and so, and so I, could provide quality work, get compensated for it, and feel like I did a good job for my patients. And I think you guys are in the same boat with that.
Definitely.
Yep.
Yeah. We've gotten some feedback about patients feeling respected and comfortable and safe when they come in, and it's like, okay, we're on the right path here, and I want to stick to that and stay away from the cookie cutter. So,
well, yeah, I don't know. Any recommendations for anyone trying to scale or grow? Like, how are you going to scale and grow what you're doing right now? I guess is a question I'm curious about.
I think the idea of slow intentional scaling is important, right? Hiring clinicians who care about quality, creating systems where therapists and prescribers communicate, keeping session lengths clinically appropriate, measuring outcomes and not just profit is really important. So at the end of the day, if like your North Star, your guiding star is patient well-being, growth becomes sustainable instead of exploitative. And so for me right now, it's just going to be a matter of, hey, this is how much I can take on right now. I don't want to take on too many more patients because I know I may not give them enough time. But once I'm ready, I'm going to bring someone on. And so it's that slow, intentional scaling part for me that's really important. And that's where I'm at now. And, I think we've talked about this a little bit as, I might, as we, talked about my in-person space in Eden Prairie, now that I have that, I feel like a bit more ready to like bring on maybe a therapist or maybe a drug counselor or maybe a nurse practitioner or a physician assistant who might want to also do prescribing alongside me. And so there's a few directions I'm thinking about going, and we'll see what that looks like.
Great. Yeah.
Well, Talha, thank you. Thanks for joining us today. This has been a grounding and a clarifying conversation. I really, really appreciate it. Although, I mean, we covered quite a few topics, and just your insights on all of those.
For sure. And you know what, I'm thinking, appreciating your insights into this, and also, I want to say your mindset about doing things collaboratively with therapists, and just how important that is, and how therapy and medication, aren't siloed by any means, and they work best when they, working together.
So before we wrap up, we do always like to ask what you got going on right now, Talha. It can be anything at all, whether it's something you want to promote or share, or just something you've been thinking about. Anything, you got a lot going on. Can you choose one? Maybe is the better question.
Yeah. Well, I mean, right now, like we talked about, Comprehensive Psych Solutions is continuing to grow. I'm seeing people, like I said, in person in Eden Prairie, but telehealth across Minnesota, Illinois, Ohio, and California. So that's keeping me busy, focusing on thoughtful, individualized psychiatric care. And, we're always welcoming referrals and collaboration from therapists and other providers. So, I know you guys are in the same building, so it's always nice to have a place to send people for therapy. What do we have going on? Actually, this Wednesday, the National Association of Social Workers, the Minnesota chapter, is hosting their social worker social hour at Mindful Spaces from 5:30 to 7. So that'll be
fantastic.
Cool. And so we're excited. We're excited to have them over at our space. So if you guys are interested in popping by, they're going to be doing some tapping exercises. Social workers can learn that and get some CEUs from that as well.
Fantastic.
Oh, when is that again?
That's this Wednesday.
Wednesday. Okay.
Right.
Oh,
I'll have look.
Okay. Yeah. Great. Huh. What else is going on? Paul, what about you? What's on your plate right now?
Geez. All the work's always on the plate. But I'm really excited about the snow because my son's Nordic skiing season is just kicking off. So fingers crossed, we've got enough snow that he can actually have his first meet on Wednesday. So I probably won't be making it. But I guess we'll see if they decide to call it as good enough.
So that's cold enough.
Yeah, well, definitely going to be cold enough.
Okay.
And there's enough snow on the ground for, a few 100, 200 skiers to scoot across. We'll see.
Yeah. Oh,
how about you?
Well, me, you know what? I have a workers' comp audit. It's a lot of fun. But I have to complete this workers' comp audit, and they wouldn't let me in the other day with the old login that they sent me. So they finally sent me a new login, and I'm going to go at it.
All right.
That's great. And maybe hopefully split some wood this weekend. We're thinking about that. Oh my gosh. Oh,
that's funny because I got an email from my workman comp yesterday, and I have to submit mine by December 20th as well.
Well, there you go. You guys so
there's a lot of honest stuff there as well. Yeah.
Oh my gosh. And shoot.
I did want to ask you, so no more chopping wood by hand?
It's been years. When I first moved out, to the place we're at, I did a lot of that. Oh my gosh. And I'm wondering, how did I ever get that done? Well, I was younger than you, probably. Yeah. Okay. Oh my gosh. Yeah. No, the wood splitter, and it comes, it tips up so you don't have to lift the logs onto it. It's pretty cool.
Oh, now we've got with this piston fix, we're going to have two wood splitters.
There'll be two splitters now.
We'll be able to have a lot of fun.
Oh my gosh.
Do either of you ice fish?
Oh, not really. My one son-in-law does a lot of it, and he's excited.
Yeah,
for the cold.
I'm like a twice a year guy.
Yeah. How about you?
I've never been, and so I'm like, maybe this is the year to, find somebody to go out on the ice with. But I think we're still a ways from that. Maybe another month and a half, maybe till it gets cold enough.
Oh, you know what?
Depends on how long it stays cold. As long as it's thick enough.
Yeah, he's saying in some lakes, and you could maybe get out there at the end of this week. If you're just walking out there. Mm-hmm. I would never do that. But he knows. He's good. The other thing you can do is you can go up to Lake Mille Lacs or whatever and rent a fish house, an ice house for the night. And you can stay the night and you can eat chili and pickled turkey gizzards and things like that.
That sounds like a good a good
was
time.
A few years ago I did that too. Oh shoot. Okay. Enough of that.
I don't know about the gizzards, but I might pick up on that rental house. I'll look into it.
Okay.
Yeah, they're out there.
Yeah, for sure. Well, okay. What are we finished here?
I think so. Getting a little punchy over there, Jim?
I'm getting a little punchy. It's going to be that time. I think I'm being directed to say something like, make sure you follow us wherever you get your podcasts and share this with a colleague or two who might find this helpful. And we'll go from 14 or 15 to 20 or 30 people.
We've had so many good guests on this.
Yes.
Talha, for sure. And all of our guests, I've really appreciated the conversations that we've had. And I do believe as we keep growing and get this going, people cycling back through some of the great information, stuff that we've shared in this and that our guests have shared are going to be, it's just going to keep picking up and cycling all the way around. So I'm really excited for us to be hitting that tipping point. I think it's coming soon. As we keep throwing more marketing and everything behind it, this is really going to be this is going to be a really helpful tool, I hope, for a lot of providers all over the place. And with that too, we have our weekly newsletter, Trade Winds. And so we announce everything in our weekly newsletter. So you can go sign up for that on our website. And that just focuses again on behavioral health news. So go sign up for the newsletter, Trade Winds. Listen, share this. If you know anybody who is wanting to start a practice or thinking about it, or wanting to grow it, that is where we're at with what we're doing here at Breezy. So until next time, I guess
keep your eyes on the horizon.